The Greater New Bedford Community Health Center monthly video series is brought to you by Senior Whole Health, a health plan for seniors that have both Medicare and Mass Health coverage. Online at seniorwholehealth.com.
Welcome to the Greater New Bedford Community Health Center. We will be presenting a series of seminars which we hope will inform the community and our staff about the benefits which are available to the people that we serve.
Hi, my name is Cruz Martinez. I'm the Director of Patient Access here at the Greater New Bedford Community Health Center, and I want to welcome you to the Senior Services Group. And on behalf of Peter Georgopoulos, President and CEO of Greater New Bedford Community Health Center, I would like to welcome Pam Gossman, Executive Director for Senior Whole Health Program, and the topic for today's series of seminar is what is a senior care option plan. Pam?
Thank you, Cruz, and thank you for everyone for coming, and thank you for Greater New Bedford Health Center for holding these seminars, because it's a great institution and a great place to be. I wanted to go over the Senior Care Options Program. I happen to work for one of these plans, but there are others in the state, and I think everyone in the state of Massachusetts should recognize how Massachusetts has been at the forefront in doing something new and really beneficial for its population that are 65 and over. It is a program that has been around now since 2004, and it seems to be growing. And I was just telling someone I see this model of health care actually changing other health plans and the way we do health care in general in the United States. I've seen a lot of changes this year that these kind of programs have influenced the changes. First of all, it's a really unique kind of health plan. It only serves people who are 65 and over in the state of Massachusetts. The health plan has to accept full risk for all their Medicare benefits and their Mass Health benefits. So we get money from Medicare and Medicaid to combine everything into one model. People can enroll every month, so it's year-round enrollment. It's not like the Social Security Administration, that Medicare, it's a once-a-year enrollment. You can enroll monthly. If you don't like it, you can drop out monthly. So it gives the member a lot of flexibility. It's a really high-touch model of care management, and it really believes in keeping elders and healthcare services in the local community and making best use of those services. It also addresses poverty issues and psychosocial issues. I'll tell you later on about how important the local elder agencies and other social services are in supporting the healthcare for these members. And also it provides great flexibility. Traditionally, Medicare says these are the rules and this is what we pay for. Mass Health says this is what we pay for. What the SCOs are allowed to do is pay for what the individual needs. So it's not like benefit limits. You reach a certain limit on the number of rehabilitation days that you can have. You can actually have more if the doctor and your healthcare team think you need more. Key principles is to keep the funding coordinated, to use the finances more efficiently, to reduce admissions to hospitals, to reduce admissions to nursing homes for long-term care placement, and really get the whole system talking to each other about that individual who's in the middle of that healthcare system. It also provides far more home-based services than people could get otherwise. People may need personal care assistance, help with laundry. That's put into the home with the goal of keeping people at home and as healthy as possible without admissions to hospital or nursing homes. And also it's really a comprehensive, that's why our program is called Senior Whole Health, because it's comprehensive. It looks at the whole person, not just when they're sick. We want to look at when they're in the home and what other factors are influencing their healthcare status. So what's unique about senior care options in Massachusetts is that it was a CMS, where Medicare and Medicaid offices in the federal government, and a state demonstration that started in 2000. And actually I was in the early phases of this in the 1900s. We worked for the PACE program, which some of you may be familiar with, and we said this is so good, this should be available to a lot more people. So the state of Massachusetts was innovative and creative enough that they set up consumer groups and professional groups to start designing this model. And finally, in the year 2000, the federal and state government signed an agreement to make this happen. Although there are two other states, Minnesota and Wisconsin, that have something similar, Massachusetts is by far the most comprehensive and includes everyone, from those people who are well to those people who reside in nursing homes. So it has the whole continuum of care. And Minnesota and Wisconsin don't quite have that continuum like we do. In 2002, there was state legislation passed to make this happen, and I've got to say Senator Motigny was one of the sponsors of that bill and was really influential in making sure that passed. And in 2004, as of August, there were 3 official SCOs. One was us, Senior Whole Health. One was Evercare, which is also still around, and Commonwealth Care Alliance, also called CCA. By 2008, the demonstration agreement that we had with the federal and state government went away, and we were made something called a Medicare Advantage Special Needs Plan. So some of the rules changed for the health plan, but the member couldn't see the changes. We're governed by a lot more rules now under the Medicare rules than we used to be, but they're working on that, and I'll tell you more about that later. Also in 2010, Fallon Health Plan, called Navicare, entered the SCO market in Worcester County only, and they've sort of expanded their area recently. As of last month, there were over 18,000 SCO members, and I would wager that as of October 1st, there were probably close to 19,000 SCO members. There's 100,000 estimated potential eligible people in the state of Massachusetts. About 25% of them reside in nursing homes, and the rest are in the community. But it's also a growing population. We've already started talking here about the growing population of 65 and over just in your own area. And also, the economy's not good, so people aren't doing as well as they used to do. So there are more and more going on to Mass Health. To qualify for a senior care option program, you have to be 65 and older, and you have to have Mass Health Standard. That is the full Mass Health benefit package. And in Massachusetts, you can have Medicaid only, but to be under the special needs plan under Medicare, you have to have Mass Health also. So they're called dual eligibles. Like I said, the enrollment is voluntary. They can choose to enroll every month or drop out every month. And we assess the members in order to find out how their functional status is. And they're put into these rating categories. So if you have no functional impairments, they used to call it community well, but we found out they're not, we called them the community not so well. But it's the community other category. Then we have a category that's chronic mental illness and Alzheimer's dementia. And then the nursing home certifiable are those with 3 or more ADL impairments or a skilled need. And finally, there's those who reside in nursing homes because they are already in long-term care, custodial care. Why did the federal government and the state government decide to focus on this population? Well, there's more and more data coming out. Finally, the federal government is publishing this data. It showed up in the Wall Street Journal for the first time ever. Even though there's 38 million people in the United States with Medicare, and there's 50 million people with Medicaid, there's the dual eligible population in the middle that represent 9 million people. However, what's so important about looking at this population, even though it's only 9 million people, the proportion of Medicare and Medicaid spending on that population is significantly higher. So in 2007, from the Kaiser Family Study, even though 21% of Medicare beneficiaries were duals, they represented 36% of the Medicare spending. That's a huge amount. That means that they are much sicker than the rest of the Medicare population. And the same thing in the Medicaid category. 15% of the Medicaid population was represented by duals, but they represented 39% of the Medicaid spending. And a lot of that was because they were in long-term care. And the goal is keep them out of the nursing home for custodial placement. It repeats some of that, and this shows you how much they spend per capita on duals, on aged duals in the United States. Also, because Medicare and Medicaid really paid for slightly different things. Medicare pays for skilled services like hospital visits, physician visits. Medicaid pays for the co-pays and deductibles for those Medicare beneficiaries, but they also pay for more home-based services. But they're siloed, and so their biases for financing and for taking care of people really were different from really looking at the whole person and keeping them well. Also, there's no flexibility in traditional Medicare. You can't say, well, I think they need more skilled nursing days than they're allowed. You can't say that in traditional Medicare without them having to pay out of pocket, but we can do that. And there's so many rules, Medicare and Medicaid rules. And you can imagine, we used to use a slide showing you have an elder, and they walk into the doctor's office, and they have 3 different insurance cards. They have a Medicare card, a Mass Health card, and a Medicare Part D card. And can you imagine going in and knowing which card to present and which is going to cover what? It's a very confusing system. And also, no one was coordinating the care. Traditionally, Medicare and Medicaid don't pay for care coordination. This again shows you some idea of how much sicker these people are than traditional Medicare and Medicaid people. Far more disabled. We were just speaking about how many come from the under 65 population and move into the 65 and over, and they had disabilities. But you can see education's far lower, their incomes are far lower, and their functional impairments with the activities of daily living are far lower. And again, lots of chronic diseases. On average, our members have 5 chronic diseases, which is a huge number. So what happened? You can see the segregation of the 3 programs. Your Medicare benefits that were for acute services and so forth. Medicare Part D that covers your prescription drugs. And then you had your Medicaid services. And it was fragmented. No one had responsibility for seeing, if you went for a Medicare service, no one went to see what happened when you went home. There was no follow-up, no transitions of care. And there was little incentive to reduce nursing home care. And also, nursing homes sort of, to make the money, they want people to go to the hospital because they would get more Medicare money when that person came back into the nursing home. So there's always this financial incentive that's contradictory. What the SCO hoped to do was align the Medicare and Medicaid programs through the state and federal partnership. It wanted coordinated care and it wanted quality care. It wants individual care plans called ICPs. It wanted to promote independent living and quality of life, and it wanted to achieve cost savings through prevention. And these are the goals that were set. Diane Flanders was a real lead person in the state of Massachusetts, and these were the goals that she cited for the SCOPE program. And this is what I was talking about before. Medicare pays for the above services. Medicaid for home care, dental, vision, transportation, those types of services. But this is what a SCO adds. You get a medical home. You get a care management team. Every member has to have a primary care physician or a primary care nurse practitioner who is the head of their primary care team. But you also get a nurse care manager from the health plan who's in the community doing assessments in the home, talking to that doctor's office, communicating with the pharmacy, communicating with the member, communicating with the daughter who's always taking care of the member. That is a critical piece of the SCO model. Also, all the SCOs were required to contract with their local elder service agencies, and we chose to contract with every one of them wherever we had a member, because we really believe in the public health model that keep the care in the community. They know the community, they know where the services are, and they know their people. So we contract with all the ASAPs in our service area. And also, there's other team members. We have pharmacy consultants on staff. We have about 5 right now who will go out and work with the local pharmacists, will communicate with the doctor's office. We also have behavioral health specialists who are part of the team if that's needed as well. And again, I said there's individual care plans. Every member gets an assessment. If they have higher needs, our nurse goes out and does a home assessment. If they look like they're community well, the ASAP sends a caseworker in. And even if you're well, we want a baseline. We want to know what's going on in the home. If anything does happen to your health, who's there to support you, or do we have to look at that? And also, they keep in touch with us so we can catch really early if something's changed in their status, if we have that baseline information. And we're required to do periodic reevaluation. So the nurses are at least out in those homes every 6 months with those nursing home certifiable members. And the ASAPs have someone out at least semi-annually for the community well. So this is the SCO model of care. It's an interdisciplinary team, and this is all in our contract. This is the way we had to do it. And I know this is familiar to community health centers because you guys have been doing this kind of model for a long time. It's not so new out there with other practices. The primary care physician or nurse practitioner is the focal point for clinical decision making, and the member and the member's designated caregiver or family member is always part of that team decision making. Our nurse is available 24/7 by phone or by email or through our electronic records. They really try and coordinate the care with the PCP and the members. It's called a geriatric support services coordinator. This was a word made up in our state legislation, GSSC we call them. Those are the care managers from the ASAPs. And they also, like I said, do in-home assessments and identify and organize the home-based services. And then, as I said before, we have other specialists depending on the needs of each member. This is how it works. That circle with the individual in the middle is really key to the whole model of care. We have a centralized electronic record that our nurses and our GSSCs and our other staff use to record every piece of information we get. We get daily downloads of what prescriptions they're actually filling, so we know they not just got a prescription, we know if they're compliant in using that, and if they're not, our nurses can contact the doctor, the pharmacy, whatever, and see what's going on. We have face-to-face meetings in the doctor's office sometimes. Sometimes we have telephonic communication. That's pretty ongoing. And it's coordinated across the hospital. We're responsible for the hospital payments, the nursing home payments, the home-based service payments, the physician payments, the medication payments. So that makes us responsible to make sure it's all being coordinated. As I mentioned earlier, we categorize them into non-complex care members with low risk and complex care members, which are the nursing home certifiable and the members with chronic mental illness or Alzheimer dementia. And again, these are all state prescribed assessment tools that we use in order to identify who are the highest risk members, and so we can really keep targeting those high risk members and provide the services. We also have in our plan we have nursing home, long-term care nursing home residents with their own specialized SNF, we call them nursing home facility nurse care managers. They're people who really know how to manage care in the nursing homes. All our payments from Medicare and Medicaid are risk adjusted based on the risk of the member. So for Medicare, they base our payments, monthly payments, on diagnosis of the members, whereas the Medicaid dollars are based on the functional status. And this is all done through the assessment tools. For Medicaid, we have 24 rate cells. So it all depends on which town they live in, how sick how bad their functional status is. So there's a lot, but it's all pooled. So we don't have to say this is Medicare money, this is Medicaid money. We pool it so we can do the best for the member. So these are the benefits. I think there's a lot of benefits. A lot of benefits to the patient in terms of having a nurse care manager and care management team, people in the home. It's flexible benefits. Another important aspect is we really give support to the caregivers because we know how tired they are. There are respite services for the caregivers, just getting in-home services for the member to give that caregiver some relief, because they are counted in the healthcare dollars. Those caregivers are doing it for free, so we don't want them to burn out, and they need the support as well. Also, no SCO member pays any out-of-pocket costs, not for Part D, none of their medications. There's no co-pays. It's all free. And also, there is less chance of a nursing home placement. There was a study by date that showed that SCOs have reduced nursing home placement 42%, and that was by the second year of operation. And they haven't done a third study, but just to do that by the second year of operation is pretty amazing. There's benefits to the physicians as well. Usually physicians have to bill Medicaid and Medicare and do collections. We reduce all that administrative burden. SCOs have transportation services. Physicians don't have to fill out PT1 forms, which I understand are a pain to fill out. So we've reduced some of that administrative burden. And also they can call one place if they have any questions about what's going on with the prescriptions and how can we help with different things. Hospitals and SNFs, again, one full payment, no separate billing for Medicare and Medicaid, reduced administrative burden. And then what's so important to the hospitals right now is that we've actually showed that we reduce preventable hospital admissions. And hospitals in, I think it's January of this coming year, will no longer get paid for a readmission within 30 days if it wasn't necessary. So hospitals want this kind of thing to happen because they don't want an unavoidable admission. Again, we have teams of people helping go from hospital to nursing home to home and back to make sure the services are in place, because that's where people fall through the cracks. And also, there's no 3-day rule. Traditional Medicare, you have to be in a hospital 3 days in order to get payment for rehabilitation services in a nursing home. And then there's benefits to the Medicare and Medicaid programs. Medicaid's saving money by not putting people in nursing homes. That's a huge cost to the state. It's about $74,000 a year to put someone in custodial care. So just think what you can avoid in that. And again, we've reduced hospital admissions, so Medicare doesn't have to pay for those dollars. And there's real evidence that the quality of care is improving for this very high-risk, vulnerable population. This is some of the outcomes. I mentioned already there's a study that the state of Massachusetts conducted with the SCO data showing that we've reduced nursing home placement to 42% compared to Medicaid fee-for-service population. And not only that, if they did have to go into a nursing home, it was usually in the last 6 months of life. It was usually end-of-life care, and they were much older than traditional populations going into the nursing home. We also have so many quality programs and initiatives that we're responsible for under Medicare. There's a star rating system, so we're constantly collecting data and doing quality improvement programs. And now the state is also has other quality improvement programs that they monitor the SCOs on. And I've got to say, there's really always been really high consumer satisfaction among all the SCOs. There's low voluntary disenrollment. People do not choose to leave these programs very often, and if they do, they tend to come back because it's so high touch. Now, the changing landscape in healthcare in general, I think what we're seeing, even at the federal level, is more talk about the dual population that are using a lot of the healthcare dollars and the need for integrating Medicare and Medicaid. CMS is talking about this. We just had the Office of Management and Budget came out to look at our model of care because they have heard about the SCOs and how well they're changing the landscape in healthcare. And they really think that this integrated approach to healthcare delivery has value for this complex population. Also, I should tell you, the SCOs serve a population that most do not speak English. 67% of our members do not speak English. And we have 37 languages as of last count. So it changes. And so the SCOs have bilingual, multilingual staff because it's so important to that population. The federal government also created a Federal Office of Coordinated Healthcare for the first time. This came under the new ACA Act. Medicaid and Medicare, if you can believe it, at the federal level never talked to each other. They didn't know what their rules were, and so they're just being engaged for the first time. There's a person who's head of that office named Melanie Bella, and she's getting people talking, and they're talking about the conflicting rules for this population. And there's a lot of work going on to even set up demonstration projects about coordinating this care. We have federal government people contacting us about what do we need to change in the rules because it doesn't make sense for this population. Also, there's a new Center for Medicare and Medicaid Innovation that Congress has directed $10 million toward. And what they're doing is looking at these kind of programs that do care coordination, improve quality of care, and reduce the costs of care. And so the state of Massachusetts does have a $1 million grant that they received through this office to start developing an under 65 SCOTE-like program. And what I understand is that they hope to have an RFP out by next April. But there's lots of regional meetings about this program, and they're looking at SCOs and some of the rules and what's worked and what's not worked in order to develop the same program for people under 65. Also, the state has something called the Patient-Centered Medical Home Initiative, and again, it's like the SCO model. There's a payment for the high-risk members to care manage them. We're the only SCO involved in it, but we make a payment, manage a care fee to help manage the high-risk members. We make that to the health center to help do the care coordination, and there's data sharing and so forth. So the SCOs sort of fit right into this model of care. So it's really changing, and I have to say, for me personally, it's been the most rewarding job I've ever had, that I got to see something from the start, and it's about the people. I visited a lot of our members, especially in Fall River, New Bedford, because that's where we started. I visited the first 250, just so I could get a sense of what it was like. And they have stayed with us. They've died with us, but it's really rewarding to see how it's changed their lives. Jersey Cabatis is here. She's from your community. She's on our staff, and she has a story. I find that stories really give the sense of what this program is about. So if you could just bear with her to just give a brief story about how it's changed people's lives.
I'm Josie Capataz, and back in 2004, I was working for the Diocese of Fall River. And I was working a lot with isolated, depressed seniors. And Senior Whole Health came up to me and said, "Here's our product. This is what it is." And I was like, oh, this can't be true. This is by far out there. This can't be. So I spoke to my director at the time, and she's like, well, call Senator Mark Montigny and find out what this stuff is all about. So I did, and we worked very hard to get this through and passed, and go ahead, spread the word. So I was running a very informal church group with isolated, depressed seniors in Fall River, and I had Senior Whole Health go and present. There was one woman in the group who, if you saw her, you would think she's homeless. She lives on Columbia Street somewhere in somebody's backyard or something, and she has no family. Well, she wasn't homeless. She just didn't have anybody to take care of her. So she was actually the first person in my group that I had enrolled with Senior Whole Health. And within 3 weeks, if you saw her, you would not say or think she was homeless anymore. And it was the first time she said anybody ever cared for me. She had been abused by 2 husbands and by her 2 sons. So I was like, well, this works. This really works. And I did become an advocate of Senior Whole Health and this whole school model. And a lot of the seniors that I was working with were becoming Senior Whole Health members. And my last story is a recent story. And I ran into a caseworker, and he's like, oh, Senior Whole Health, I'm like, yeah, I'm with them now. And he said, I work at a hospital, and I see people that go into the OR. And he had a woman come in her 80s with her husband for surgery. They did not speak a word of English, and he asked, who's having surgery? And she goes, I'm having surgery. And he, opens her file. She's having knee surgery. He's like, is your husband dropping you off? She's like, no, he's staying with me. And he's like, no, he can't stay with you. And it's like, no, I take care of him. I don't want anybody to take care of him. It's me. And he's like, but you're going to stay in the hospital for a few days and then go to a facility for rehab. She's like, yeah, but he needs to stay. And no, he can't stay. So what happened was he called Senior Whole Health, her caseworker, and within less than an hour, he was in a facility where she then in 2 days got transferred to. And they were roommates while she had her rehab done. So, and I say this is the difference in having a senior care option plan. This is not a global insurance plan that everybody has. That this is your insurance plan. It works for you and your need. So it's not just all these benefits, and there's so many benefits. But I think one of the biggest benefits to the member and to the caregiver is actually the peace of mind. This whole theory behind the senior care option plan gives everybody. That's my story. And I would have a lot more to tell you.
Thanks, Josie. Thanks. And just on a closing note, I do want to say I really think the state of Massachusetts was visionary. And you've got to give them credit for going ahead with this. And I think the landscape of healthcare is changing, just as community health centers. I mean, community health centers do this kind of work as well, so it's really critical. Any questions? Peter.
Hi, I'm Peter Georgopoulos. I guess a comment. There are people that are going to be watching this in local public access, so they might be asking the question, how do they contact you, or who would they call?
Well, there's 4 SCOs, Senior Care Option Program. So one thing they can do is call the Senior Care Options line at Mass Health, but also they can call your health center, and you can refer them to our toll-free number.
I guess another question is, you said that there are people that do not pick up the prescriptions and you monitor that?
Yes.
Do you have an idea what the percentage of people of that would be?
I don't. Our clinical people would, but they may pick them up, but they don't pick them up. That's right. They get the prescription, they don't pick them up. But we can track that on an individual basis. And like for your health center too, we could look at the membership in your health center and see who's compliant and who's not compliant. And our pharmacists will come out and work with your docs because they have a medication therapy management program that they can work on with that. Anything else? Well, thank you very much.
Thank you, Pam. On behalf of Peter Georgopoulos, President and CEO, and staff, I would like to thank Pam for the valuable information provided, and also the heartfelt stories by Jurasi Capataz as well. Thank you so much. The next series of service group will take place November 7th. The guest speaker will be Terry Larson, and the topic will be Coastline Elderly Programs. Thank you.